me, Dr. Kukreja is there, Dr. Minesh Gandhi, Dr. Dave sir, Panchal sir is there.
Right.
So
Good afternoon, everybody.
why you are planning this procedure in a prone position? What is the advantage of prone position?
And there is a sorry to disturb you. There is a one last case. Mostly we are taking rectovaginal fistula in OT1. We are just taking that patient. Still anesthesia is pending and pending dripping is pending. If time
नाम दिखाओ
permits,
मेरे को,
we
नाम
will show
दिखाओ।
you. That is will be operated by
Stapler
Dr.
का नाम।
Pankaj R. Modi sir. So
Box.
now audio is transferred to Dr. Praveen Gore sir.
Yeah. Yeah, hi.
Praveen?
Yes. Yeah, Dr. Vijay, I heard your question. Basically,
Yeah, the question is, again, I'm repeating,
I want to know the
why the
name
prone
of that
position
box.
is, what is your preference? Or,
So, so basically there are three biggest advantages. One is the patient is more relaxed and the chances of femoral neuropraxia because of a hyperextended lithotomy position is not there. The second is the light can be really focused very well. And the third and the most important is the surgeon as well as the assistants will have good vision inside. Otherwise, in lithotomy position, I am sure we all have experienced, it is such a nightmare for everybody to assist properly.
Yeah. Vision we can understand, but the chances of what you're telling about neuropraxia, hardly we come across any because we do all the proctology cases in a lithotomy position.
Yes, sir, you are absolutely correct. But sometimes what happens is, out of over enthusiasm, they do a little hyperextension, and if the surgery lasts for a longer time, then it becomes a little challenge. And unfortunately, I have experienced femoral neuropraxia in 3 of my patients. So that's the way दूध का जला छाछ भी फूक फूक के पीता है. So once you have experienced a complication, next time you will always be more careful, isn't it?
Yes, sir.
So you are,
sir, myself,
you are yes, sir.
Yes, sir. Myself, Dr. Minesh Gandhi from Bayard. Sir, will we get the proper exposure as we are getting in the lithotomy position, sir?
Yes, because of the position. So what we have done is we have strapped the buttocks.
So have you put something below the belly?
Can you repeat the question, please?
He's asking just a plain position, or is it a jackknife position?
It is a jackknife position. We have pillows underneath.
Okay.
And
so
the buttocks,
are
the
you
buttocks have
standing
been
by the
strapped.
side of patient or in between the legs?
No, I am on the side of the patient. I am on the left side of the patient.
Okay.
Because I am artery forceps, please. Pakado. Cut. Give me one more vicryl, please. Cut. One more vicryl, please. So after I have taken the Pakad.
So these sutures are very close to mucocutaneous junction?
No, this is a little on the skin rather than the mucocutaneous junction, because at the mucocutaneous junction, when we pull, the chances of tear are very high. The tensile strength of skin is much higher as compared to the tensile strength at the mucocutaneous junction. Out. So there are two ways. Some people put the anoscope first and then fix it. I first fix the put the sutures and then I put the anoscope and fix it. So like every
is there
mother.
Is the advantage of this over putting the anoscope first?
I'll show you when I am putting it.
Okay.
And always remember my first sentence which I have told, दूध का जला छाछ भी फूक फूक के पीता है. So I have had all these complications in the years which made me alter, and that's what happens with all the surgeons, no? Yeah. In our journey of surgery, we come to know what works for us and what does not work for us. Hold this, hold this.
Okay. Is it a male patient or female?
This is a male patient.
Okay.
Leave thumb, put it here. बाहर बाहर. दूसरा हाथ का thumb, put it here. Okay. Now don't move your thumb. That is most important. I will go around your this thing wherever I have to go. Okay.
Sir, can we use silk in place of this Vicryl?
Sorry, I had actually asked for a linen. Plain, simple, sada, sasta, sundar, tikau, 40 mm ka 40 size ka linen. But unfortunately, it is not available. The Gujarat government is really very patient conscious. And I have been blessed to be provided with a Vicryl for stay sutures. Unfortunately, I feel it's an overkill, but then so be it. So whatever ration we have, accordingly we prepare our dish. Na?
But what we can see, the needle is very much traumatic or large.
No, it is a cutting needle. Na?
Cutting large needle.
Yes, cutting large needle. But then even when we... chhod de. Yes. Cutting large needle. Even when we use the skin linen, there also we usually use a larger needle. Now, give me a needle wala dhaga. जितना भी बचा है. नहीं. Give me that needle. हो गया 3 हो गया तो बस हो गया. Mercedes Benz sign. 3 अगर पिलर आ गया तो your circular dilator is in position.
प्रवीण,
Yes, here doctor.
क्या ये मर्सिडीज बेस साइज क्या है?
चार sutures है ना यहाँ पे. So even if you have fixed 3 sutures, then this CAD will not come out. So 3 pillars are enough. 4th pillar is always better. Now here, I would just like to demonstrate what Dr. Shivpuje was mentioning. Ki why did you take the sutures beforehand? Chhod do. Now after fixing this, put your hands here. After fixing this, when the surgeon tries to put the sutures from here, you don't know how much depth you are going inside. And when you come out from here, you don't know how much you are coming out, and there is a lot of injury which happens, which leads to bleeding. And then after that, it is easier to tie. The second is, many people, what they do is, they put the sutures from inside out or outside in and secure only the outer rim. So that does not give that much enough of stability. Whereas when we fix it over here on these bridges, the stability is much better.
Yeah, I got it.
Yeah.
Yeah, and because we saw actually Nitish demonstrating other way.
Yes.
So he had a bit difficulty while putting these sutures.
Yeah. So all these sutures. Now what I would always do is, I will explain my assisting staff what steps am I going to do and what they are expected to do. तो जो मैं आपको बताऊंगा वही आप करोगे तो अपना सर्जरी जल्दी भी हो जाएगा, क्लीन भी हो जाएगा. ओके, अभी बटरफ्लाई, द अदर, ये इसको हम लोग बटरफ्लाई बोलते हैं. राइट, यू कैन सी इनसाइड. Alice their sister. Hey, Gospis. Yeah. Now let us do a sponge test. So when you put inside and you see how much of the mucosa is prolapsing. So there is a lot of lax mucosa which is around here, and there is a circumferential involvement of this happening. So that is why we selected MIPH for this patient, because he had a circumferential involvement of hemorrhoid. Prolin 10, please. Long needle holder, long plain forceps, 2 artery forceps, only 2 artery forceps. Remove the remaining from the.
So are you planning to take a counter suture at 3 o'clock?
Yes, sir. Now here in a prone position, I will be starting the suture at 9 o'clock according to the lithotomy orientation. Now here this is anterior near the scrotum, this is posterior near the coccyx, this is the right of the patient and this is the left of the patient. And I really appreciate, I am sure you all must have appreciated the way Dr. Pradeep Sharma sir has written on the skin while doing the pilonidal surgery, so that we as a surgeon, we get a proper
orientation is very important.
Yes, yes.
While understanding, yes.
Yes. So what we will do is, we will take 1 artery forceps to this step, do what I tell you to do. Just hold this please. Yeah. So that in the vogue of our suturing, sometimes what happens is the end gets pulled up so much that you are not left with enough suture to make a purse string. दूध का जला छाछ भी फूक फूक के पीता है, मेरे साथ हो चुका है.
बहुत छाछ पी रहा है.
हाँ अभी बस छाछ, गुजरात में छाछ ही पियेंगे ना भाई. पकड़ो, होल्ड दिस प्लीज. राइट सिस्टर, यू कम ऑन दिस साइड प्लीज. इसका जरूर. Right. So here now our dentate line is already protected by this circular anal dilator. We will just lift the mucosa. ये हाथ से इसको थोड़ा सा बाजू में कर.
So how much above you are going above the dentate line?
At least 2 or 3 centimeters above the dentate line. And it is difficult because my hand will be coming in the way of the camera to appreciate this suture. Now what happens is my pronation is finished over here.
Yes.
The more I do pronation, it is dangerous or difficult. So it is better I again supinate and pronate. छोड़ दो. हाँ अभी कुछ मत करो. ये धागा पकड़ो, प्लास्टिक छोड़ो, प्लास्टिक पकड़ो, धागे को यहाँ पे पकड़ो. सिस्टर आप उंगली से इसको दबाओ. ओके राइट. धागे को ट्रैक्शन में रखो, पुल थोड़ा सा पुल. देन वी टेक अनदर राइट and we go a little deeper. धागा छोड़ो, धागा छोड़ दो, छोड़ दो, छोड़ दो, नहीं तो झटका बैठे. प्लास्टिक छोड़ो, प्लास्टिक पकड़ो, धागा पकड़ो, उंगली रखो, पुल पुल, थोड़ा सा ट्रैक्शन. अगेन are you able to appreciate what's happening inside?
Yes. So what size of needle is this? 36?
No, this is. देखो जरा पढ़ के बताओ प्लीज. छोड़ो, थोड़ा सा खींचो जरा, ट्रैक्शन दो जरा. राइट. दूसरा प्रोलिन खोल देना प्लीज. ओपन द सेकंड प्रोलिन. धागा छोड़ो, धागा इसमें अटकेगा संभाल के. हाँ रिलैक्स. जस्ट इसको हल्के हाथ से पकड़ा, इसको हाँ ओपन करो, छोड़ दो, ओपन करो. वेट. The proline will always have memory, na? We should remove the memory, but when we pull it will get disconnected from here. So first we hold it over here and then we pull it. And
yes.
The last end when we pull it will coil back, spring back. So करके पूरा last तक नहीं खींचने का इसको. Now here I am taking a loop around. When I am taking a loop, I am just going across this suture.
Yes.
So this will become my loop.
Yes. So
right. So what happens is most of the surgeons initially they used to take the purse string, and after the purse string is complete they will take a counter stitch. Now in doing so you are again putting a needle inside just to make a counter stitch.
yes.
And the more number of times you put in the needle, the higher the chances of having a hematoma. छोड़ दो. प्लास्टिक पकड़ो, धागा पकड़ो, सिस्टर थोड़ा सा दबाओ, बस.
So while taking this bursting, you should not see the suture outside, isn't it?
Yes, absolutely correct, sir. Now here my supination is already completed. So I remove, I pronate my hand and then I remove this suture. धागा छोड़ो. Right. Plastic छोड़ो. You have to always pull, remove this anoscope and then put it back again. धागा पकड़ो यहाँ पे. Otherwise the rectal mucosa keeps on getting twisted.
Yes.
I believe, I don't do Dr. Chute procedure, but when I have seen in all the number of cases, what they would always do is they will just rotate the proctoscope inside rather than removing and putting it back, which is cumbersome because it has a window, you cannot remove it. And in that sense what happens is the mucosa gets folded on its own. छोड़ दो. सिस्टर प्लास्टिक पकड़ो, सिस्टर प्लास्टिक पकड़ो, सिस्टर धागा पकड़ो और आप खाली उंगली लगाओ. ये हाथ छोड़ दो. Now one another point which I want to highlight is the assistants do not know what you are doing. So a communication between the surgeon and the assistant is the most important key in having a decent surgery. Unless your assistants are trained enough because you have operated so many number of times that they know you like your wife, छोड़ दो. तभी तक उनको बेचारों को छोड़ दो.
Like wife को ही रखो ना assistant को.
पकड़ो. अरे wife को सब कुछ मालूम रहता है बाबा. देखा मैंने असलियत बताई करके all the ladies are also laughing.
So the next suture you are taking is at the same level or
almost at the same level. Plastic छोड़ो, plastic पकड़ो, धागा पकड़ो, धागा पकड़ो. हाँ. अभी now I am almost completed this bursting. Now what I have done in between is every time I remove the needle holder, I wipe my needle holder. Otherwise, after a few sutures, there is jelly and the mucus smeared on the inner side, and the needle tends to slip away. And then the surgeon shouts at the nurse, क्या needle holder दिया है मुझे? Correct है ना मैडम? हाँ. छोड़ दो प्लीज, धागा छोड़ो, धागा छोड़ो. Right. Butterfly पूरा निकाल दो. Right. Now is the time.
overlapping.
Now is the time. छोड़ दो, हो गया. सिस्टर आप अपनी पोजीशन पे आ जाइए. Thank you so much. Can you appreciate this whole bursting happened effortlessly?
Yes, yes.
Because
absolutely.
the team which I am being assisted with is fantastic. Now I palpate to see if there is any bare suture. ठीक है? And then I don't want to be overconfident. तो डॉक्टर साहब आप palpate करके देखो कहीं पे bare suture आपको महसूस हो रहा है क्या करें? Go all around, go all around, go all. सब म्यूकोजा के नीचे है ना? पक्का? Sure? Confirm? लॉक किया जाए? Done. चलो. I am so sorry to be a little light on my vocabulary because I have understood one thing. If the atmosphere of the OT is not tense, the chances of our complications are also lesser. Can you give me the stapler, please? Sister, please. जो बोलता हूँ वही करेंगे तो जल्दी खत्म करेंगे. जमवानुष है ना? हाँ. दो उंगली से जेली लगे. Yes, yes, Dr. Vijay.
Which stapler you are using and what is the size?
Can we show the box of this? No, box दिखाओ ना भाई. Only the box.
Box नहीं चाहिए
Only the
हमको.
box.
You are not supposed to show this one. Promote or any product, but just want to ask what is the size of stapler?
Yes, so I am referring to the box. It is a Helium stapler and it is 34 size.
Okay.
Okay. Now here,
Tell me.
so we are not promoting. We are just mentioning what instruments we are using.
It's
Now,
it's a 2-row or 3-row staple line.
let me see. This is 2 rows.
Okay.
One difference that I have noticed is the housing is transparent. That is the only difference.
Okay.
Right. Now I place my stapler in such a way that it goes nice and deep inside. Okay. हाँ.
Helium.
इसको ऐसे हाथ से नीचे पकड़ो. पकड़ो. सीजर दो सिस्टर. नीडल को कट करो. सिस्टर आप नीडल को कट करो. राइट. नहीं मैं बोलूँगा ना बेटा. इसको ना पैरेलल टू द एनस रखना है आपको और वहीं पे रखना है. ओके. सिस्टर मूवमेंट मत करो आप प्लीज कुछ भी. There are 7 important steps during this MIPH surgery, and one of the important step is tightening of this bursting suture. If this bursting suture becomes loose, then the chances of having an incomplete donut will increase. Sister, scissor do please. Cut karo please.
Praveen, how will you ensure that it is tight around this?
Yes, we should not see any lax mucosa around. Hopefully.
Uh-huh.
हाँ, अभी ये स्टेपलर थोड़ा सा इधर. हाँ मेरा उंगली जाने के लिए. Can you give me this please?
Sir, is there any special indications for using 2 row or 3 row, sir?
Usually in star surgery we use 3 rows because it is a full thickness excision, na? Yes. And sometimes it is patients mucosa is so tough and thick, so that we can judge it during our sponge test. And then if we have, obviously we always have, at British Candy we already have 3 rows and 2 row stapler, and that also two pieces of each.
That we will decide during operation only, sir.
Yes, interrupt.
Yes, sir.
So now this is a suture threader. One important thing what everybody does it, they struggle during threading this. So I'll tell you an easy step. Your suture threader, you just put it here. Go across and then pull it out. Easy? Let the doctor do it. पकड़ो, ये मेरे हाथ में छोड़ दो. अभी यहाँ से लेफ्ट हैंड से इसको अंदर घुसाओ. हाँ घुसाओ अंदर, डालो पूरा अंदर आर पार. हाँ पूरा उसका नॉब दिखना चाहिए. हुक ऊपर लो. ये हुक ऊपर आना चाहिए ना बेटा. हाँ लैप्रोस्कोपी करते हो, यू नो फल्क्रम इफेक्ट. अभी गो अक्रॉस, टाइट, नीचे जाओ, घुमाओ, नीचे जाओ, घुमाओ. यस, इसको छोड़ दो. हाँ खोल दो, खींचो, आ गया. इजी, पकड़ो. नहीं ये इसको पकड़ो. Right. So if you learn the technique properly, then you will not struggle during the surgery, ना? Isn't it? अभी गुजरात में पतंग तो बहुत उड़ाया रहेगा सब लोगों ने, तो कन्नी बांधने सबको आता है ना, तो ये हम लोग कन्नी बना रहे हैं. It should be equal distance, only then the kite will fly higher. In other words, if you have an equal distance on both sides, then your traction is symmetrical and your donut, chances of having a good donut increases. Scissor. Done. अभी मांझा से हाथ भी कट जाता है ना बहुत बार. So likewise, this Prolin suture can really be notorious to your finger. So I would give a protection to my own finger by putting a gauze piece over here, and then अभी मुझे मेरे पास दे देना, छोड़ दो. And then एक सेकेंड, तुम्हारा थंब लगा ऊपर, उंगली. सिस्टर इसको पकड़ो. हाँ एक थंब इधर, एक थंब इधर, थंब खाली थंब, और दोनों को दबाओ. यस, ओके. तो यहाँ पे आई एम जस्ट टाइटनिंग द स्टेपलर. दिस स्टेप तो एवरीबडी नोज हाउ टू टाइटन द स्टेपलर, but you need to be in parallel direction to the anus and the rectum. You should not be oblique. And कितना डॉक्टर नीतीश ने बहुत अच्छा बोला, even a gym goer, जिम वाला आदमी ना इसको और टाइट करने का. Yes.
In lithotomy, we direct the stapler towards the sacral halo.
हाँ.
In the prone position, where should we direct it?
Toward the apex of the bladder, umbilicus, if you can say. Done, finished. Now we wait for so-called 2 minutes. रुकना है 2 मिनट? 2 मिनट का शांति नहीं रखने का, 1 मिनट रखेंगे. ओके सिस्टर, सलाइन एड्रेनालिन है ना आपके पास? दे दो, वाटी दे दो. और एक गॉस पीस दो मुझे सर, और एक गॉस पीस दीजिए. So like Dr. Brij Agarwal always mentioned, how much time should we wait? जब तक आप आपका गणपति का आरती बोलते हो, या गायत्री मंत्र बोलते हो, या नमोकार मंत्र बोलते हो, उतनी देर तक रुकना है. Why? So that the apposition of the tissue is good enough, the edema is extracted because of the pressure, and your staple line, the stapler, will catch in more securely rather than when there is an edematous tissue. Okay? Now, थोड़ा zoom out करो please. लाइट का बटन दबाओ ना, ऊपर बटन है देखो. क्लिक, वन मोर. यस, पूरा zoom out.
Can we also have audio and video in OT1 where we've taken a case of rectovaginal fistula? The operating surgeon is Dr. Pankaj R. Modi.
Can I just finish this step, please?
Yeah, yeah.
Yeah, you can finish it.
Yeah. So
No,
here what we do is, either I can fire this way, sir.
yes,
I have
you
done more than
are audible.
600 MIPHs. Either I can fire this way, right? Or I can fire this way, or I can fire this way. Are you able to see? So if I do it this way, my scapula is already winging. So the force applied is not enough, and there may be hesitancy. So in this position, I would prefer to apply it this way, right? Now, as doctor mentioned, we remove the lock, right? And we fire. And then we remove. And then गायत्री मंत्र, गणपति आरती और नमोकार मंत्र का और एक टाइम. So we wait for a while. And then, as Dr. Nitish mentioned, you rotate it 270 degrees. अब यहाँ पे प्रोट्रैक्टर लेके नाप तो नहीं रहे हम लोग 270 degrees, है ना? So more than half a turn. And then थोड़ा left, थोड़ा right, थोड़ा left, थोड़ा right. That means there is no impingement. That means the cut is perfectly done. And the stapler comes out. और बाद में अपशगुन माना जाता है अंदर देखने के लिए. पहले पैक करके रख देना. Okay. In the meanwhile,
हाँ, फायर થઈ ગયું, સ્ટેપલર બહાર આવી ગયું, પેલું ઝૂમ
Yeah,
કરીને
પકડો.
ખાલી પેલું બતાડી દેતો શિફ્ટ.
so we'll keep the 9 o'clock long and keep the 3 o'clock short. So we get an orientation. Okay. Mop देना please sister. Right. Now we see that we have a complete donut, right? But this is not enough. This is not enough. What I would do is, स्टेपलर पकड़ो, आर्टरी पकड़ो, नहीं उसको पकड़ने, हाँ, फॉरसेप दो, सीजर दो, खींचो 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 खींचो, ये cut.
Can we have
निकला? Now we can just remove this thing
Just 1
without
minute,
cutting.
Pujal.
Done.
okay?
Without cutting. So you have a nice donut. Now what I always say is, if you can play with the donut well, that means you have exercised enough. Otherwise there will be small bridges, there will be buttonholes, there will be thick area, and
Hello?
then that is not a complete.
Hello. We are shifting the audio
Yeah.
and video to
Sure.
our to OT1.
All right.
Yeah. Thank you.
Good afternoon, everybody.
Yeah. Can you show us a staple line?
Show the staple line.
Good.
Hello.
Good demonstration.
Same speculum. Jelly लगाओ.
Hello, Dr. Dipali.
Yes, sir. It's audible, sir, and visible as well.
Okay.
So, are you able to see the case? Is there
Yes,
some?
sir. All the moderators are there,
Okay.
and the case is visible as well, sir.
Okay, so it is a rectovaginal fistula 2 months before patient had a delivery. I have passed a feeding tube through the opening, right? I think it is not very well seen, but most of the time. Are you able to see it? Yes.
Yes, sir.
Yes, same way there is a opening inside the rectum which is about 2 centimeter. What we normally, there are two methods to do it. One is we core it out and take a sutures, but it will not give good sphincter apposition. So what I do is I will first give us only saline. Normally we also give saline with adrenaline, but the patient had a history of convulsion, so I'm not using adrenaline, using only saline. So it will create a good plane in between, and my basic principle is put a transverse incision at the junction and close in a vertical incision. That is the basic principle of this RVF.
Sir, what is the etiology of this fistula?
Post delivery,
Post delivery.
menace is there.
Good afternoon, sir.
Good afternoon.
Me, Amrish and Nikunj are there. Yes, sir.
So you have become moderator from chairman?
Yes.
So all
Thanks
moderators
to-
have gone.
Thanks to Pritesh Patel.
So you can stop whenever the oration and everything starts. I don't mind at all. You can tell to the Pritesh also. This is the case we are doing because we have taken this case and we want to finish them off. That is the basic right.
No, sir, we are also interested to see this type of cases, sir.
દબાવી રાખે.
So what are you injecting? Only saline or
That I
with
said,
adrenaline?
adrenaline is better, but in this patient, I don't want to use because the patient has a history of convulsion. The patient had become fit only today morning. Otherwise, might have taken this and wait. Usually, we wait for a few minutes when we give adrenaline. Here, there is no need to wait. So, the basic principle is knife 15 number. I use the plastic knife. Put a transverse incision extending over toward the side of vagina. Exactly at the junction of this, what we call U shape or double S shape incision, more towards vaginal side, so the sphincter can be preserved. Just a minute, I will take it, right? Sometimes if you need, you can extend it on this side also, make it double S type, but this is what we like, slightly U. Tooth forceps. કોટરી કેટલા પર છે? બીજો ટૂથ આપો. ઓકે, ઉપર પકડો. Light says, are you able to see it?
Yes, sir. Yes, sir.
So once you go beyond fibrosis, there is a potential space which will be open easily. Either you can use sharp dissection or even artery forceps. So you can judge it. This is a vaginal. હજુ patient ને થોડું straight કરો ને, easily આ લોકોને દેખાય. So this is what I am doing. So I am entering, this is the potential space where the saline was given. You can see that is entered. My artery has gone in.
Yes, sir.
Same will repeat on opposite side. This bleeding is because of the non-using of adrenaline, which did not keep it very bloodless, but it is necessary. So you can see that on either side I have gone.
તમારો
Right?
હાથ વચ્ચે આવે છે.
Haji.
એટલે વિડિયો વાળાને કે થોડું ઉપર લઈ લે.
So now you can see thing, I think, right?
Yes, sir.
So on either side you can see that I have entered. This is the potential place which will be helpful. Now I will cut it vertically on the vaginal wall up to the fistula and may remove the extra part. Let us see.
Sir, please ask the cameraman to change the
Position.
angle because your
Yeah.
hand keeps on coming in
But
between.
this is the point, yes, he will have to change it. I have straightened the patient also for that reason also. Let us put, will it help or not, I don't know. Okay, now I think you are able to see it. Alice apo, chalo, let us see.
કેમેરા વાળાની મૂવમેન્ટ બહુ વધારે છે.
Now I think you are able to see it.
Now we can see.
This is the opening.
Cameraman is shaking too much.
Camera is not stabilized.
Okay, let us go to plan B. No issue. Are you able to see anything?
We can see, sir.
Clean karo. I'm sorry for that. Suction एक add कर दो तो clean था ना तो. Okay. So this is the area of fistula I have reached. I will remove the fistula and mass. लाओ पकड़ो फॉरसेप मैंने आपको सक्शन लगाई दो. This is the fistula between આ રાખજો બાયોપ્સી માટે. ચલો. Now as you can see they are practically fused here, the vagina and the rectum. So that will have laterally the space is made, but on this side suppose this is the vaginal wall, this is the rectal wall. અને છોડો આ બાજુ લે. I don't know whether
what about the sphincter, sir?
We'll show it. Still we are not reached there. We'll have to separate this portion. So even beyond the fistula they are fused. So if you don't separate them right up to the levator ani, the chances of recurrence is very high. You can see this is rectal mucosa, this is the sphincter, and this is the vaginal wall. Now this is the space I have created right up to there on this side. મને એક ગોસ પીસ આપી દો. પલાડીને સલાઈનમાં પલાડી અને આર્ટરી પર. થોડો મોટો આપજો તો રહી જશે અંદર. Okay, so this side I will repeat the same thing on opposite side. This is the external one. You can see that that is practically they are fused like anything. રાખો.
Mr. Chairperson, please ask the cameraman to